Greetings from Baltimore, Maryland, and the University of Maryland, Baltimore County. This is Professor Ilsa Lottes delivering my second talk to your medical academy. In the first talk, I presented principles of human rights and discussed the need for human rights education that begins in primary school and continues through graduate school. And I also stressed that human rights education should be across multiple disciplines. My focus on human rights is grounded in the knowledge that human rights are a major cause of harm, poor health, and suffering. If human rights are understood, then I assume that there may be fewer abuses of such rights. I acknowledge that such thinking may be both ethnocentric and idealistic. However, recent trends in the globalization of human rights provide some support for my views. As an American, I have been socialized to believe that the USA is a country that supports human rights. Yet the more I study human rights, the more I realize how little most Americans know about them and how infrequently human rights principles are incorporated into domestic and foreign policy. I propose two very broad questions for you to ponder. First, should the general public of nations be comprehensively educated about human rights? And second, to what degree should a consideration of human rights principles be considered in domestic and foreign policy decisions? Of course, if you heard my first lecture, you know that I am an advocate for human rights education and human rights principles. My knowledge of human rights has come through my work on sexual and reproductive health, and especially by following international trends in extending human rights to sexual rights. Thus, I was first exposed to links between sexual health and sexual rights, and that led me to an examination of the global health and human rights movement. In the U.S., healthcare has not generally been considered a basic human right, even though it is listed as such in the International Covenant on Economic, Social, and Cultural Rights that was opened for signatures for countries in 1966 and entered into force in 1976. In the first term of President Obama, a new health care law was enacted, and there was great political debate about extending health care coverage to those who cannot afford it. In my view, the Obama policy was simply trying to enable more people to have the right to health care. However, a large proportion of Americans and elected national health makers were opposed to the new health care law. Perhaps if Americans were more educated about the meaning of human rights, more of them would have favored the new health care law, and policymakers would have used human rights arguments to gather support for the law. Now I turn to the international trend mentioned above, namely the linking of health to human rights. I thought this appropriate, for most of your faculties in your academy are in the health and human rights professions. The basic goals of this presentation are to review principles of human rights that apply to health policy, to help health providers and researchers understand applications of human rights principles to health policy, and to understand how to use indicators to evaluate human rights applications to health programs and policies. There are several assumptions of a rights-based approach to health policy. One of them is worldwide there is a lack of understanding of human rights principles. Worldwide there is a great need for comprehensive human rights education. The realization of human rights contributes to better health, and characteristics of human rights must be understood in order to properly evaluate a country's state of health, and indicators should be used to evaluate a country's health system. There is a lot of support internationally for the view that health care is a human right. I already mentioned the International Covenant on Economic, Social, and Cultural Rights. The application of human rights is associated with the Millennium Development Goals of the United Nations. The World Health Organization also supports health as a human right and uses this view as a primary advocacy and monitoring tool. Then there are other important international documents: the Declaration of Alma Ata, the Ottawa Charter for Health Promotion, the Bangkok Charter for Health Promotion in a Globalized World, and the People's Health Movement. These are all ways that human rights has been supported internationally. The next slide illustrates some of the principles of human rights that apply to healthcare policy. The universality characteristic: health policy should apply to all. It should be the nation-state responsibility to ensure the realization of human rights, dignity, equality, diversity. I'll discuss these later. Basic components of a health policy, of a rights-based approach to health policy are: number one, all health policies and programs should be evaluated for their positive and negative impacts on the human rights of all. Formulators of health policy and practice need to be aware that rights violations have health impacts, and health programs can improve human rights, and human rights awareness can improve health programs. This last component implies that there is a positive synergistic relationship between health and human rights, and wherever possible, there should be a human rights expert in on the planning with other health professionals in designing health policy. There are a number of examples of how rights violations contribute to poor health. There are many harmful practices around the world, such as genital cutting and honor killings and child marriage. Torture and dignity violations, unfortunately, occur in most countries. Slavery exists in the world. Unsafe and unhealthy working conditions are a problem. Lack of clean water, food, and nutrition lead to poor health. Discrimination and stigma are examples of a violation of the dignity and diversity principle of human rights. And then lack of information also leads to poor health, and the right to education is a human right. Some other characteristics of human rights and health approaches are participation by all the people affected by a policy, definition of measurable goals and listing of indicators to evaluate a program, accountability of both administrators and participants of the program or health policy, and inclusion of groups most vulnerable to health outcomes and rights violations. This is the basic one. All health policy should involve participants that are most vulnerable to human rights violations, and those participants often have poor health incomes. I want to quote again from Jonathan Mann, the founder of the Journal of Health and Human Rights. Damage to human dignity may have more serious adverse effects on physical, social, and mental well-being than infectious disease. I am also advocating that people look at social determinants of health, 6 general categories of indirect social determinants of the right to health care for all, and I have published on these and elaborated on these different factors in all of these basic categories that need to be looked at to properly evaluate a system's health care system and to avoid violating human rights. Now, I want to say that a large part of my views have come from an article that was published in The Lancet in 2008, December 13th issue of The Lancet, the British medical journal. And this journal comprised a list of 72 indicators of the right to health, and it applied these indicators to 194 countries. And there were 14 categories of indicators of the right to health, and I've listed these categories on the next 2 slides, and in parentheses I have indicated the number of indicators that are used to measure each of these categories of human rights. And on the next two slides, you will see all of these 14 indicators with the number of indicators in each category. One of the main categories of indicators was awareness raising about the right to the highest attainable standard of health. And there were 5 indicators here, and of these awareness raising indicators, there were actually no countries which included these indicators. That is, there was no data on information on the awareness raising about the right to health. Some of these indicators from category 1 was recognition of the right to health. Some of the indicators were the number of international and regional human rights treaties recognized by the right to health by the nation state. Does the state's Constitution, Bill of Rights, or other statute recognize the right to health? In category 2, which is non-discrimination, example of some of the indicators were the number of treaty-based grounds of discrimination that the state protects, the number of non-treaty-based grounds of discrimination that the state protects, and then just general provisions of the state about discrimination. The authors found that there was a great deal of missing data on many of these indicators, and there was also a question about the reliability of the data. In order to meet the universality, equality, and diversity requirements of rights-based approaches, one important indicator that was listed under the health and information category asked, does the state disaggregate data in the civil registration system on grounds of sex, ethnic origin, rural or urban residence, and socioeconomic status and age? So data needs to be disaggregated in order to evaluate the universality and discrimination aspects of rights-based approaches. Another question is, does the state have a national human rights institution with a program of budgeted activities to raise awareness of the right of health among doctors, nurses, and the general public? Are human rights needs a compulsory part of the national curriculum for the training of doctors and nurses? Does the state's national health plan recognize explicitly the right to health? And does the state's national health plan include explicit commitment to universal access to health services? These are important questions that health administrators and health providers need to ask for themselves. The basic conclusion from the 14 experts who wrote this article in The Lancet, the basic conclusions were: number 1, most countries have not incorporated human rights into their national health policy in a systematic way. These experts recommend using the indicators they listed as the basis for monitoring the process of health systems in their efforts to improve health care for all. And they also stated emphatically that right to health features are not just good management, justice promoting, and humanitarian. They are obligations under human rights laws. I welcome any comments and questions about this presentation. My email is listed on this slide. You may even write me in Russian, for I have many Russian friends who will be eager to help me translate or to do the translation for me. I also want to inform you that I will be in Jyväskylä, Finland in the fall, developing human rights courses, including online courses in human rights. If any of you are interested in those courses and their curricula, let me know. The last slide presents an abbreviated list of references for you to look at. I advise you to look at the Health and Human Rights Journal, which is accessible free online. Also, I gave to your head of your international management my article on sexual rights, and she will be, I'm sure, happy to make that article available to you before it contains many, many more references. Thank you very much.